This is Dr. Andrew Young at St. John's in Santa Monica, and today we'll be talking about how we determine femoral rotation in total knee replacements, specifically with the use of robotics. And this talk will be very technical. We'll look at alignment, we'll look at robotics, we'll look at the three different axes of rotation. And so this will be geared more to those who have a very deep interest in the technical aspects or in robotics or in the engineering that we do. But before we get into the technical aspects, it's important to step back and understand why we place such an emphasis on femoral rotation. Femoral rotation is one of the most difficult aspects to measure in joint replacement because it involves the third axis and it doesn't necessarily show up on X-ray. And the main purpose is, number one, to optimize the relationship between the patella and the femur, and that's called patellofemoral mechanics. And secondly, to optimize the relationship between the tibial and femur in flexion. So we're looking at, number one, patella tracking, and number two, having a balanced flexion gap. And I'll show you what that means as we move along. Okay, so when we're looking at a knee replacement, we're often used to looking at x-rays and seeing a knee as a two-dimensional object, but of course we all know it's three-dimensional. And so there's what we call a coronal plane. When we look from the side, there's a sagittal, and then we look along the length of the bone, that's axial. And so we have an X, Y, and Z axis. And along those axes, we can translate, we can move side to side, up and down. But for the purposes of this talk, we're talking about how we rotate along the axis. So, for example, along the sagittal axis, we can either flex or extend. Along the coronal, we can either put it in varus or valgus. And specifically for this talk, if we look along the axis of the bone, specifically the femur, we can externally or internally rotate the femur. So again, this goes back to geometry. We have three planes of movement, and we're specifically looking at the rotational aspect along that axis. The way we measure femoral rotation is by using a combination of anatomic and CT-based landmarks. There are 5 different ways that we can measure. The most common way, the most accurate way in all anatomic studies is what we call the epicondylar axis. So this is the medial side, this is the lateral side. We're specifically looking at an axis from the lateral epicondyle to the sulcus of the medial epicondyle. Not the most prominent part, to the sulcus. That's called the surgical epicondylar axis. And then we look at the posterior condylar axis. We look at the transverse axis, or what we call Whiteside's line. We also make sure that our cut is neutral to the tibia, and then we also look for what we call the piano sign to make sure that we have more external than internal rotation on the femoral component. This process has become substantially more accurate with the incorporation of CT scanning, because now we can see all the different landmarks on the bone itself, and this allows us to plan ahead of time exactly how we expect our rotation to appear, and then it gives us landmarks that we can aim for in the middle of surgery. We get a CT of the leg, and from that we make a three-dimensional reconstruction looking at all 3 axes. So this is the coronal axis, this is the sagittal axis. For the purpose of this talk, we're looking at the axial axis, and we're looking about the rotation around that point. So this epicondylar axis, or what we call the surgical or the transepicondylar axis, is determined anatomically from the CT scan. It's not by estimation, it's not by feel, it's determined exactly by its appearance on the CT scan. So using the CT scan, we'll mark the lateral epicondyle, and then we will mark the sulcus. Here's the prominence, this is the sulcus. This is actually the true epicondylar axis. So we'll mark it on the lateral as well as the medial side so we know exactly how we want our rotation to be aligned. As another check, we will also look at the posterior condylar axis. This is our three-dimensional reconstruction. This allows us to look at the back of the knee along the posterior condyles. We'll make landmarks, and we'll also make landmarks distally, and then we can see how we rotate in relation to the posterior condylar axis. Now, once we've determined our rotational landmarks, we will then look very specifically at a series of checks to ensure that we are placing the component exactly where we want it to be. This is the first check. Remember, the primary purpose of establishing femoral rotation is for patellofemoral mechanics. And so the green is the actual virtual implant, or the virtual implant. This is the actual surface of the patellofemoral groove, and we want to make sure that this groove matches this groove. This slide ensures that we have the appropriate patellofemoral tracking. We'll then look over here. This one allows us to see sizing. We want to make sure that our implant is within the boundary of the bone so that it's not oversized. And in this slide, we're making a final check of our rotation. We want to make sure this green line, which represents the axis of the implant, is parallel to the trans-epicondylar axis. We can see that qualitatively, but we can also see that quantitatively. We can see it's not internally, it's not externally rotated, it's a neutral rotation. And then we can also see that it's classically about 3 degrees externally rotated to the posterior condylar axis. It doesn't have to be, but in this example it does. And then our final check will also be visual. This is a classic landmark that we use along the anterior femoral cortex. This is medial, this is lateral. What we'd like to see is that our cut extends further along the anterior femoral cortex laterally than it does medially. So we have this asymmetry of this grand piano sign. In contrast, an internally rotated femur will have what we call a double bubble. It will be symmetric on both sides. And so we want to see this asymmetry to make sure that we have sufficiently rotated the femur. And then also with the use of robotics, we can look down the axis of the bone and see that we're parallel to the trans-epicondylar axis and externally rotated in relation to the posterior condylar axis. Now, these checks are there to make sure that we approach the right spot, but the actual balancing of the knee with the trowels in place tells us that we have achieved the balanced flexion gap that we're hoping for. And so we have the knee at 90 degrees of flexion, and then we can see we have 18 millimeters on both sides, and so we have a balanced flexion gap, and we can see that rectangular box that we're trying to achieve at the time of surgery. So that was a deep dive into femoral rotation, and again, remember, the whole point of determining femoral rotation is so that the patella and femur track well and that you have a balanced flexion gap. We use landmarks ahead of time to try to achieve that. The landmark itself does not represent proper rotation. The landmark is used so that you can achieve proper rotation. So remember that distinction. Thank you very much.